It's a pleasure to be here today. I'd like to thank Dr. Ramaiah and the organizers for the opportunity to attend this outstanding symposium. I'll be giving a complimentary lecture on the challenges related to endovascular management of aortic occlusive disease in the current era. These are my disclosures. As you've seen, aortic occlusive disease has been differentiated based upon the involvement of the aorta iliac segments, whether it's stenotic or occluded, based upon the task A, B, C, and D categorization. And until recently, endovascular repair for task C and D lesions has really been a challenge. Often criteria were relegating them to management by open repair. Yeah. Now, the global guidelines have looked to simplify this differentiation of the disease, basically dividing into a stage 1 and 2, 2 being that with more chronic total occlusions, and also a subset of A and B, with or without the involvement of the common femoral artery, which certainly has to be taken into consideration when you're managing this problem. And we all recognize, at least the surgeons in this room, that the gold standard for open repair is the aortic bifemoral bypass, which historically has good results at 5-year patency rates of 85% and 90% respectively, and 10-year rates between 75% and 85% respectively. But we all recognize that it comes with it a lot of comorbidities and potential complications, and there is certainly a risk of major complication and death related to this procedure. So over time, because of this, we've pushed the envelope trying to determine, do we stent, do we use balloon expandable or self-expanding stents? Do we selectively stent? Do we directly stent? And when do we stent, depending upon the type of lesions? Here you've heard about aortic unibody balloon expandable stent grafts, or we even use covered stent grafts in a different variety of circumstances. So this group looked at the comparison of endovascular management of predominantly task 2D aortic occlusive disease, comparing this to open surgery, and they broke this down based upon the criteria seen to the right. And they demonstrated that at 2.7 years, endovascular reconstruction versus surgical bypass had equivalent rates of survival, limb salvage, and primary or primary assisted patency. They demonstrated similar clinical improvements, and overall they concluded that at least in the short run of 2.5 years, you could really perform an endovascular repair with similar outcomes in these patients. And this is a sick population, and therefore there is a role for that. And we know the co-best results that it basically demonstrated that the task C and D lesions do better with covered stenting versus bare metal stents. So as we move on from there, we look at the use of an aortic unibody or an endovascular aortic bifemoral bypass, the results of which you've just heard, nicely described. And ultimately, what are we really doing? Well, we're trying to recreate the aortic bifurcation in the presence of severe plaque. And the question really becomes, when we place these stents, are they undersized? Do we adequately, do we lose space in the creation of this? So the geometrical consequences of kissing stents was looked at by Goverdi and Rainian and his group. And here they did an in vivo model looking at this, trying to determine with a variety of stenting positions and placements what was the best, ultimately concluding that the CERAB configuration with the limb starting in the tapering part of the aortic cuff was related to the best geometrical condition with the lowest radial mismatch and high stent conformation. And from there, they moved into demonstrating their CERAB technique, which really is using a 12, at least in Europe, the 12 millimeter balloon expandable stent that was then deployed about 1.5 to 2 centimeters at lowest in the aortic bifurcation. And then the proximal part of that is then over-dilated to create sort of a funnel. And then you, within that, place 2 covered stent grafts coming through. And then Dave Minion actually published this nice article where he dealt with lesions that were or juxtarenal, where he used thrombolysis for a day from a brachial approach predominantly, and then actually was able to show regression of the occlusion, and therefore not obviating the need to manage the renal arteries in that situation. So that's one option. And then these investigators, again, Gerverdi's group, looked at juxtarenal problems, and they used chimney grafts in the renals and mesenterics and showed that in a very small group of patients, this is certainly feasible and effective. And then Hani Zaid looked at a meta-analysis looking at a comparison of aortic iliac disease, looking at standard endovascular therapy, the CERAB technique or open bypass, and ultimately demonstrated that at 30-day, the morbidity and mortality for standard endovascular therapy and CERAB were favorable, although open surgery had favorable primary patency rates compared to the 2 groups. and the secondary rates were comparable as well. But in this case, we did not have long-term follow-up for the CERAB. It was only after 3 years. But then this single-center study looked at 44 patients that they treated with the CERAB technique, and they demonstrated good primary patency rates at 60 months or at 5 years of 83%, assisted primary patency of 90%, and secondary patency of 95%. The 30-day complication rate was fairly acceptable, as there mostly were minor complications. And then the 5-year data for the CERAB technique did come out showing good primary assisted and secondary patency rates listed here. It was interesting that they noted that the primary reason for loss of patency was in a patient that had a prior aortic intervention. So they looked at the data at 5 years without those patients and showed much even better results, equivalent to aortic bifemoral bypass. This is just a case of mine, a patient with multiple comorbid factors, multiple stents placed in the aortic bifurcation over time, presented with occlusion of her aorta and iliac system. This is her aortogram, and this just shows you all the stents that are there. I was able to cross, shockingly, I wasn't sure I could cross all these stents, but I was. And I had to calculate the measurements of the stents, the sizes, and all that to make sure I could fit the CERAB device within. But it did work out ultimately, and then I usually patch these patients as if they have 50% or greater stenosis of the common femoral artery. This is yet another case, a woman on oxygen with aortic occlusive disease. Again, a terrible-looking aorta, again, successfully treated with the CERAB device. And this is another patient that I treated who ultimately had severe PAD, had aortic iliac occlusive disease, and ultimately this was really challenging because I couldn't cross from below at all. I had to cross from above. I had to use brachial access. I actually didn't appreciate the severity of the calcium. When I was really finally able to cross, I did predilate, and I used shockwave lithotripsy, which I think was helpful. Here you can see her aortogram, and my accessing this in the completion angiogram. And this is the run. Here, the one on the left is pre-stenting with the shockwave lithotripsy, so it's fairly good. And then the completion with the stents in place, which really looks much better, obviously. So in conclusion, the data supports superiority of covered stents for task C and D lesions over bare metal stents. We acknowledge that. The less than satisfactory outcome with just using kissing stents, so we search for other ways to address this. The clinical and technical outcomes of CERAB really are compelling, particularly in those patients that have not had prior aortoiliac stent placement. The ultimate goal really is to improve the primary patency rates and provide a less invasive operation for these patients. Thank you for your attention.